The broadcast is now starting. All attendees are in listen-only mode.
I close my eyes and I can see a world that's waiting up for me, that I call my own. Through the dark, through the door, through where no one's been before, but it feels like home. They can say it all sounds crazy. They can say I've lost my mind. I don't care, so call me crazy. We can live in a world that we design. 'Cause every night I lie in bed, the brightest colors fill my head. A million dreams are keeping me awake. I think of what the world could be, a vision of the one I see. A million dreams is all it's gonna take. A million dreams for the world we're gonna make. There's a house we can build. Every room inside is filled with things from far away. Special things I compile, each one there to make you smile on a rainy day. They can say it all sounds crazy. They can say we've lost our minds. I don't care if they call us crazy. Run away to a world that we design.
Every night I lie in bed, the brightest colors fill my head. A million dreams keeping me awake. I think of what the world could be, a vision of the one I see. A million dreams is all it's gonna take. A million dreams for the world we're gonna make.
However big, however small, let me be part of it all. Share your dreams with me. You may be right, you may be wrong, to say that you'll bring me along to the world you see, to the world I close my eyes to see. I close my eyes to see.
Every night I lie in bed, the brightest colors fill my head.
A million dreams are keeping me
A million dreams, a million dreams. I think of what the world could be, a vision of the one I see. A million dreams is all it's gonna take. A million dreams for the world we're gonna make.
for the world we're gonna make.
Good morning, everybody. That was one of my favorite songs, really, really favorite songs. It was from a famous movie, which I forget the name of, but the man that was the star of the movie, Hugh Jackman, was actually visiting my coffee shop one morning. Too bad I wasn't there. I would like to be. He was with other famous movie stars that were there, which I already knew. So Song always makes me happy. I'm Dr. Minarsik, and today is Tuesday. It's March 22nd. It's the second day of spring. The first day of spring yesterday was like the first day of summer. It was just as warm outside as it was inside, and I took a long, beautiful hike. It just felt so good, except everything wasn't green yet, not even any buds on the trees. This is going to be our 49th webinar of the year. It's called SMS3 because it's our third webinar on the skin and musculoskeletal system. And the part of the skeletal system that we're going to be talking about today are the joints. And we're also going to throw in a little bit on soft tissues. What are soft tissues? Well, you're probably the tissues in your body that are part of your musculoskeletal system, which are not really bone, okay? How about joint and what they call soft tissues? I don't have anything else to say. I hope you enjoyed the coffee today. How about if we close down the ugly guy and put up the beautiful PowerPoints? We're going to start out with a general description of the features that are characteristic of almost all synovial joints. Even the little bones in your ear are synovial joints, believe it or not. When they connect with each other, the hamel, anvil, and stirrup, you got two bones, and they have to articulate with each other. So the first feature is that they have a cartilaginous hyaline cap, what they call an articular surface. But then the interspace between the two is filled with a lining called synovium. Synovium is connective tissue, but it's also two special kinds of cells, one of which act like fibroblasts, and the other ones are immune cells called synovial cells also, and they are macrophages, believe it or not. Then there's cavity of the synovium, of which the fibroblasts, or one of the synovial cells, secretes various compounds, which makes them nice and oily. And then the tendons from each bone, and sometimes the muscles too, cross the joint cavity and they attach to the bone. And some of those tendons actually originate, believe it or not, from the fibrous part of the periosteum. So I guess you could say there's four things. There's a cartilaginous cap, there's a synovial lining, there's two bones, and there's tendons. That's pretty much the feature of just about all the synovial joints I could think of. We're talking about joint diseases today. What could go wrong in that system there? The general term for just about any type of joint disease is called arthritis, and many of them really are true or have inflammatory components. But I would say a good generic word for any type of joint disease and arthritis, even though some of them do not have the classical features of what we talked about in acute and chronic inflammation, but many or most of them do. So we'll be talking about the number one arthritis in the world, which everyone's going to get, probably you, osteoarthritis, and then the big rheumatoid arthritis, the autoimmune disease, and variants and things that are called seronegative rheumatoid arthritis because they don't have the rheumatoid factor, but there's various types like ankylosing spondylitis, psoriatic arthritis, the arthritis you get with inflammatory bowel diseases, particularly Crohn's disease, a reactive arthritis, often following many GU and GI infections. And then we'll talk about some of the bugs that actually like to cause havoc and inflame the synovial joints. And remember, we're talking about synovial joints. There are other joints in the body where there's nothing but fibrous tissue between two bones. Those are not synovial joints. Those are synostoses. And then there's another type of joint where you have basically just a little piece of cartilage between two bones, like the pubic symphysis, or a synchondrosis, like you have in the spine, where there's a nice big fat piece of hyaline cartilage between two bones, rather than fibrocartilage like you have in a symphysis. Talk about gout, pseudo-gout, and then some tumorous conditions, of which maybe only one is a true neoplasm, and it's rare. But the things that can cause growths or bumps, like a ganglion, a giant cell tumor, which may be more of an inflammatory situation than a tumor, but it's like a tumor. And then something that you'll hardly ever see, a synovial sarcoma. We'll mention that when we talk about the soft tissues as well. Okay, well, here's the biggie. What was once called and still called osteoarthritis is probably better termed now degenerative arthritis. You could probably call it the mother of all degenerative diseases because it is a true degeneration. And what degenerates is actually the hyaline articular cartilage as a early form, okay? Now, for it to be a good disease, you have to have not just this pathogenesis, but etiology or risk factors, morphology, and clinical expression. What's the etiology? It's still generally known as sort of idiopathic. I wish I could tell you there's one particular gene that's so universal, related to age, related to trauma. You know, athletes might get it before old people do. And it's a multigenic or multifactorial type of inheritance. There's not one single or two, three prominent genes I could rattle off for you. The morphology, starting out radiologically and pathologically, is thinning or erosion of the hyaline articular cartilage. Sometimes the word eburnation is used to where the entire cartilage is eroded and the underlying bone looks kind of dense and marbleized. I think that's probably the only time in your life where you'll ever hear the word eburnation. Some of the bone lying underneath forms cysts and weakens and forms these little blebs because of the pressure without the buffering of the cartilage. And these little blebbings are called osteophytes. The osteophytes can break off into the joint space and they could run around like joint mice, and that's exactly what they're called, little pieces of osteocartilaginous tissue within the joint space roaming freely. Well, what's the clinical expression? Because we have to have four to make it a real disease classically. Pain, limitation of motion. Okay, that's the main two clinical expressions, one of the four features to make this a classical disease. And here's a nice diagram. On the left is a normal joint. You got bone, you got articular hyaline cartilage, which is normal and uniform in thickness. You got your synovial lining, and you got your capsule, which basically is composed of tendons which cross the joint space. In a osteoarthritis or degenerative arthritis, you can probably say one of the earliest things is erosion of the cartilage, and sometimes complete erosion, which you have exposure of the underlying bone. The bone then loses its buffering, okay? It could then be on the basis of being subjective to forces which are usually buffered, degenerate, or actually deform, okay? You have an altered contour of the bone. These little bumps can be called osteophytes. If they break off, it go into the joint space, which is still lined by synovium, but you can imagine now it looks thickened because it's inflamed. They could become joint mice. And of course, you could have cysts in what they call the subchondral bone. So the cystic spaces within the bone are usually pretty close to where the cartilage is already thinned. I'm going to show you a joint mouse. Don't be afraid, it's not a real mouse. Okay, here we go. I don't know what joint this is. I guess it could be a knee. You can see some shagginess of the cartilage, and you see a little free piece of bone surrounded by cartilage floating around freely in there. And here we go. Here's a nice little bone cyst or subchondral cyst, very nicely demonstrated by x-rays and CT, of course, as well, where you have bone, but the cartilage, which is now not only thinned, but looks like almost completely eroded, has these little cystic spaces underneath them in the bone as well. On the basis of that, you can have an unevenness. Okay, we don't see it here, but on the basis of this now damaged, more likely to be compressed and malformed bone, you could have these little bumps along the surface, which are called osteophyte. Osteophyte breaking off into the joint space could be called a joint mouse. There might be another name for it, but that's what all the orthopods call them, okay? So here we go. Here is some nice pictures. The radiologist, of course, will be looking at this clear space between the two hyaline articular cartilages, and if it is narrowed or absent, you could say that's going to be pretty much diagnostic and easily found. Okay, if you have the pathologist actually examine that joint for some reason, you're going to see the cartilage has been thinned and perhaps even almost absent, because you can almost see the color of the bone here like you see here. So here the cartilage is thinned, and here the articular hyaline cartilage is just about absent. Sometimes the bone surface becomes sort of marbleized, and that's the term eburnation, okay? Here is the same picture I showed you before. Looks like a femoral head, thinned cartilage, cystic spaces, not quite yet so much deformity on the bone. And you're probably saying, well, why the hell is Dr. Minarsik showing us this? This is not a synovial joint. This is a synchondrosis. This is a vertebral body. But you can have these changes also even in joints which are not classical synovial joints. This you can see some of the bumpiness of the anterior portion of the vertebral body itself, and you could probably call these osteophytes microscopically. You'd see bone and maybe even a little bit of cartilage in there too. Okay, here's another picture, a lateral, where you could see anteriorly there's practically absence of the articular cartilage, hyaline, less density, almost bone going directly to bone. Many bone scans are done on patients with arthritis. Actually, this is probably what you might see in many patients that have cancer, elderly patients also with arthritis. The osteoarthritis, the changes of degenerative arthritis often result in increased osteoblastic activity, and that's why it might show up as hot knees. And remember, this is generally a symmetrical process, okay? You can see both shoulders, you can see both knees. I don't know if I would call it in the spine. You might see a little hot spot there. That's probably where he was injected with the radiopharmaceutical as well. Here's another hip in which you see just about complete absence of the cartilaginous cap and perhaps a large osteophyte because of the deformation of the bone. If you remember, or no, you don't remember because we haven't talked about it, but in rheumatoid arthritis, the most significant changes are in the MP joints, but then there's the PIP joints and the DIP joints, okay? Well, in osteoarthritis, the classical swelling is in the distal interphalangeal joint, the dip joints, and those are called Heberden's nodes. In rheumatoid arthritis, the primary swelling is more proximal in the proximal interphalangeal joints. They may be called Bouchard's nodes, but the most prominent, and we'll see it, swelling and deformity of the joints in rheumatoid are in the metatarsal phalangeal joints. Here's a arthroscopy in a knee, it looks like, and you could see extreme shagginess of the cartilage, irregularity, and probably even erosion here and maybe here as well. Okay, these are the classical pictorial imaging, intraoperative clinical findings that you might see in osteoarthritis. Okay, let's move on to another type of arthritis. This one usually with more marked inflammatory changes. It's called rheumatoid arthritis. When we talked about immune diseases, we told you to beware and not just consider rheumatoid arthritis as a localized autoimmune disease. It is a systemic autoimmune inflammatory disease. It can affect just about everything, okay? Skin, blood, soft tissues, blood vessels, heart, lungs, muscles. But the principal area of attack is the joint, okay? In that attack, the inflammatory attack, the autoimmune attack, the cells attacking their own tissues, the IgM antibodies attacking the FC or crystallizable fragments of the IgG antibodies, I'll say that again. The primary area of inflammation is autoimmune. It's where your own IgM antibodies attack your IgG antibodies, and that's called a rheumatoid factor. Because of that, there's a progressive destruction of articular cartilage, soft tissues, and even to the point where the resulting fibrosis results in ankylosis, or the loss of ability to actually, for that joint to actually work. Okay, let's get into some of the features now, and we'll show you that what we told you before is that the synovium of any synovial joint basically has two functional cells. It has a lot of connective tissue cells underneath it, but along the surface, okay, what boundaries the synovial cavity are two types of cells. There's what they call synoviocytes A and synoviocytes B. And synoviocytes A are derived from fibroblasts, but they're not classical fibroblasts like you see in the underlying connective tissue of the synovial membrane. They actually secrete the lubrication for the joint space, specifically a couple of compounds, mucopolysaccharides called hyaluronan lubricant. That's a good name because it lubricates the joint space. Then the second type of cell, called the synovial B cell, technically the nucleus is deeper in this 2-cell thickness, but it sends its processes, its dendrites up towards the surface and between the synovial A cells, and those are cells that are derived from macrophages, okay? And like macrophages, they do have an immune functions. They also have a phagocytosis function. They can also become multinucleated. And let me tell you something. You see this little membrane here? Probably mostly because of the macrophages, it is an actual magnet for immune complexes. So what is the immune complex in rheumatoid arthritis? What is the rheumatoid factor? Well, it's the protein IgM attacking the Fc fragment of the protein IgG. Okay, that's the primary area of autoimmunity, based once again on failure of the MHC complex. And this is the primary target of inflammation of rheumatoid arthritis in the joint. Okay, now for rheumatoid arthritis to be a real disease, it needs 4 things, just like we said with degenerative arthritis. What's the etiology? We said it, failure of immunity. Okay, failure ultimately of the mechanisms controlled by the MHC. Your antibodies are attacking your own antibodies, okay? It is therefore, in its pathogenesis, cellularly a progressive synovitis, but could it attack and fibrose and destroy all of the tissues lining around the synovium. So we're going to see infiltrates of lymphocytes, even some neutrophils, but primarily lymphocytes and macrophages, plasma cells, neutrophil. It's a whopping chronic and acute inflammatory change, okay? Reaction of the osteoclasts as well to try to regenerate new bone if the bone is destroyed. Something called a pannus, which is a thickened portion of the fibrous tissue. So the pannus of rheumatoid arthritis is an area of fibrous tissue secondary to fibrosis. In the acute phase, there's a lot of hyperemia like we have in acute inflammation. You can have little fibrous nodules, not only in the joints, but anywhere in the body. In the lung, is a common place, but anywhere in the body, these so-called rheumatoid nodules. And last but not least, like many, or if not mostly all of the systemic autoimmune diseases, there's a vasculitis, okay? So the rheumatoid vasculitis could be completely in areas that are not part of the joint. What's the clinical expression? Well, just like any arthritis, just like what we saw with degenerative pain, limitation of motion, malaise, fatigue, and the positive rheumatoid factor. And once again, here we have an IgM molecule, the big Ig immunoglobulin, attacking the Fc, or the crystallizable fragment of the IgG molecule. Remember, the classical IgG has the Fc, called C because it was the part that could be crystallized. But then there was the FAB, which is the part that has the variable portion as well as a stable portion, which determines where this thing comes in contact with the antigen. So if you could imagine an IgG molecule attacking this Fc portion, you now know what the rheumatoid factor is. And here we go histologically now. You got an inflammatory reaction, chiefly lymphocytes, T cells, trapped immune complexes within the macrophages. Remember, those are the type B synoviocytes. You have pannus, or secondary to the chronic inflammation, you have proliferation of fibrous tissue. Look at this, it's whopping. It almost looks like a lymph node, okay? This is a whopping synovitis. Here we have surface cells, and here we have a whopping amount of chronic inflammatory cells, mostly lymphocytes, but also the macrophages attacking this. And this is a rheumatoid nodule. It may not be part of the pannus that you see in the joint itself. It could be somewhere completely different in the body. And don't forget, you can also have a vasculitis, which could theoretically involve any blood vessel in the body as well. So how do you diagnose it? Okay, well, this is one of those diseases where you can take like a little list. I don't like this, but this is what is seen very often in the textbooks. You could often diagnose this by taking a careful history. If the patient complains of morning stiffness, and specifically morning stiffness lasting at least 1 hour, okay? If the patient complains of arthritis in 3 or more joint areas, of course the earliest and most likely are in the joints of the hands, particularly the PIP joints. Remember, those are the Bouchard's nodes, the metacarpal phalangeal joints, the MP joints, the wrist, elbows, perhaps moving up to the shoulder, ankle, so forth. And these are actually swollen. They have the classical features of a inflammation: heat, redness, swelling, and pain. Remember that? And if you have arthritis of the hand joints, particularly in a symmetrical fashion, a symmetric arthritis, that's another feature. Rheumatoid nodules, these could be actually anywhere, not just over the bony prominences or the extensor surfaces, but in regions which are not directly in the articular region, the juxta-articular region, or even far away from it. Subcutaneous, somewhere else in the body. Positive rheumatoid factor, a test that's easy to perform. And of course, the radiologic changes, excuse me, particularly in the hand. And many of these things, of course, you don't need x-rays for, you don't need labs for. There's often, as the obviously clinical finding, what they call an ulnar or medial deviation of the MP joints, which we're going to see. So that's basically some of the features, and if you take them together at some point in time, it increases your probability that you're dealing with rheumatoid arthritis. So arthritic symptoms plus a positive test for rheumatoid factor would be a generally good way of summarizing this thing. And let's take a look. Look at how these MP joints, okay, there's the metacarpals, there's the phalanges. Do you see how they're thick? And they cause a deformity where the entire finger deviates towards the ulna. And remember, in the anatomic position, the ulna is media. So medial or ulnar deviation of the MP joints, including the thumb. Probably most physicians of any type, when they would see something like this, they would just say rheumatoid arthritis, okay? That's classical. Radiologically, here's a normal hand. Radiologically, here's a hand in which you can see ulnar deviation and thickening of the joints in the MP area. And of course, the next place would be the proximal interphalangeal joints, the so-called Bouchard's nodes. But probably MP joints even more likely. Here's one in which we could see blown up an MP joint. I believe it's this could be a PIP joint, in which you could see irregular changes in the joint surfaces. And here's one where you can see a lot of irregularities in the MP joints. MP joints, PIP joints, DIP joints. Okay, another form of rheumatoid arthritis is juvenile rheumatoid arthritis. If I didn't mention it, and I probably should have or didn't, rheumatoid arthritis in itself is way more common in females than in males, okay? But there is a variant where even children, and technically somebody that comes in with rheumatoid arthritis symptoms before 16 might be generally thought of as probably having juvenile rheumatoid arthritis strictly by the virtue of their age. And generally, where we says the rheumatoid arthritis in older women starts out in the smaller joints of the hand as a general rule, the joints involved in juvenile are generally larger joints, knees. And of course, besides having classically the rheumatoid factor, they have another positive test, which is probably found almost at one time or another in just about all of the systemic autoimmune diseases, particularly lupus, is a positive anti-nuclear antibody as well. So what's juvenile rheumatoid arthritis? It's features clinically of rheumatoid arthritis in kids under 16, generally probably in larger joints, and very, very likely are positive often to have an anti-nuclear antibody. These people might be worked up for lupus as well as rheumatoid arthritis. They usually have a positive rheumatoid factor though. Here we go. Well, what about the arthritides, which is plural of arthritis, in which you don't have the positive serology of a rheumatoid factor, okay? But they still behave or look in many ways pathologically and clinically like what we talked about in rheumatoid. Well, there's a disease, you could probably call these the HLA-B27 arthritides. In other words, they may mimic rheumatoid arthritis, but the patient probably has a HLA-B27 antigen. HLA stands for human leukocyte antigen, and these are the antigens that are on the surface of white cells. And there's one called B27, and that they're positive for that antigen on the surface of their white cells. They are at risk for forms of arthritis which are not classically rheumatoid. Now, an ankylosing spondylitis, now we're talking about the spine. Technically, it's not a synovial joint, is it? But you could have rheumatoid type changes with fibrosis to the point where the spine actually becomes ankylosed, which means the joint doesn't work. And whereas the classical rheumatoid arthritis was way, way more common in females than males, ankylosing spondylitis makes up for it because most of the patients with Marie-Strumpel disease or rheumatoid spondylitis or ankylosing spondylitis are usually males with positive B27 antigens. Another type of arthritis is generally called reactive as an adjective because it follows infections of the genitourinary or GI system, okay? And the classical example of that would be Reiter's syndrome, which somebody that has not only a urethritis, but a conjunctivitis as well. So you get a patient that has a urethritis as well as a conjunctivitis. He may very, very well be HLA-B27 positive. You could measure that in the lab. Not every lab, but a lot of labs will do it. And then people with inflammatory bowel diseases, particularly Crohn's, but also ulcerative colitis, often thought of as being sort of autoimmune diseases as well, because there's no obvious infectious pathogen involved. Okay, those are patients that may have an arthritis, and there are could very well be HLA-B27, and they may follow GI or GU infections. So what do you do with a patient with Crohn's disease and also have an arthritis? That person would fit the ticket here, wouldn't he? Now, we talked about psoriasis a couple of webinars ago as one of the major types of chronic inflammatory diseases, basically in the knees and the elbow areas. We talked about the histology and risk factors and all that. People with psoriasis may get an arthritis too. And if they do, very, very likely, or they could be HLA-B27. So what would you say is the one feature for the types of arthritis that may mimic rheumatoid arthritis, but they don't have the rheumatoid factor, or they don't follow all of the other clinical scenarios? They may very well be HLA-B27 positive. Here's a Marie Strumpel, or what we called ankylosing spondylitis. Here's a normal spine. Okay, you could see that they basically, the synchondrosis, the cartilage, hyaline cartilage between the vertebral bodies is pretty clear, but the tissues that support this, both anteriorly as well as posteriorly, can have these inflammatory type changes to the point where it actually causes a dense fibrosis between the vertebral bodies, and in this case you can see some density here in the anterior aspect of the joint, and up here you could see increased density changes in the sacroiliac joints, which are basically part of the spine also. So that would be Marie Strumpel or ankylosing spondylitis, HLA-B27 likely, and maybe looking a lot like rheumatoid. But remember, these are not synovial joints. What are some of the bugs? Well, probably the most type of infectious arthritis might be something that comes from an actual osteomyelitis, because when osteomyelitis extends to the joint, you now have an infectious arthritis, okay? And osteomyelitis very often are the suppurative type bugs, like Gonococcus, okay, staph and strep, H. flu, E. coli, and of course in patients with sickle cell, salmonella is not only the number one form of osteomyelitis, but also can extend to the joint as well. And like any type of arthritis, and not to exclude the infectious, whopping, suppurative, this is the type of arthritis that's going to be loaded with neutrophils if you tap the joint. Okay, we'll have the classical signs of inflammation, heat, redness, swelling, and pain. I think that we have a word for those in Latin as well. Fever, leukocytosis, and increased sedimentation rate, because with the serum proteins alpha-1, alpha-2 being elevated, that results in the cells, the red cells, slowing down to settle within a test tube. So it's an elevated erythrocyte sedimentation rate due to the increased number of acute inflammatory proteins, namely the alpha-1 and alpha-2 globulins, okay? TB can infect the joints. We talked about a special form of osteomyelitis called Pott's disease, where TB could infect the spine, but it can also infect the joints. In fact, there's only like a couple parts of the body, and I think thyroid was one, and maybe skeletal muscle was two, and I can't remember the other two, where TB cannot cause damage. But the joints are no exception. You could have a granulomatous tuberculous type inflammation in the joints. Lyme disease, okay? The early clinical acute Lyme disease often has as its number one symptom joint pain, okay? And that's because the ticks family Oxydes bites you, releases a little spirochete called Borrelia burgdorferi, or usually Burgdorferi, okay? And that's the bug that actually forms the the source of infection in acute infectious Lyme disease arthritis. Viruses, sometimes there's a arthritis associated with hepatitis C, rubella, German measles, and the parvovirus B19, often seen in young children, can produce a arthritic type of picture also. Okay, let's take a look at gout. And I want to say that today, the last two webinars were actually whopping. We did over 100 PowerPoints, for these. Today is going to be not bad at all. There's not even half as many. So after we talk about gout, we'll take our break and probably finish way, way, way before the 2-hour limit. But gout is a common form of arthritis too. Some people would like to say that gout is due to buildup of uric acid from people that have increased uric acid. But that's like doubly wrong, because it's not actually uric acid that does the damage. It's a uric acid crystal called monosodium urate. It's not the acid, it's the salt. It's the monosodium urate. And also, these things form little crystals called tophi. And tophi are monosodium uric acid crystals due to increased buildup of hyperuricemia. But the second fallacy is that it's not just a hyperuricemia, because a good portion of the population, we'll say, look, 10% here has hyperuricemia, but only a very, very small portion of those have gout. Okay, so it's not just hyperuricemia, and it's not just uric acid. It's hyperuricemia with other problems, and it's not the uric acid, it's the urate salt, forming a foreign body giant cell reaction around these crystals. Clinically, it could be acute, and that's also characterized by the classical acute inflammatory cells, the neutrophils. Clinically, it could be chronic. They're treated differently. They will give you medicines for acute gout, and there's another type of maintenance sort of medicine for chronic gout. So you're probably asking yourself at this time, why is it that if you can have a high uric acid and most of the time not have gout, but other people with that same high level of uric acid will get gout? Well, the answer to that, I still believe, is not really known, but there are some genetic factors we'll talk about. And here is basically the classification of gout. Most of the gout, 90%, has high uric acid, not because of the inability to excrete it from the blood or from the body, but because of overproduction. So most of the patients with gout have normal excretion, okay, but they have overproduction, and that's called primary gout. Now, if they had decreased excretion, that would explain it, but a good portion of those, even though they have increased excretion, they still have a overproduction, which overwhelms that, okay? Now, technically, could you have an under excretion from a physiologic point of view, producing the hyperuricemia? Yes, you could, but that is not very, very common. Now, there's an enzyme, a very important enzyme called HGPRT. Okay, you could have a genetic defect of it, or you could just have a relative defect, okay, in that enzyme, in which there is an overproduction of uric acid. Why is it? Because HGPRT, it attaches a purine base, in other words, guanine or hypoxanthine, to a sugar. And what happens when you attach a purine base to a sugar? Well, you create a nucleotide. Well, if you have a defect of that, you now can have theoretically an overproduction of uric acid. Now, in a relatively small percentage of gout, only about 10%, You can have them whenever there's an increased turnover of cells that have nuclei. In other words, nucleic acid, for example, leukemias is the number one possibility. Sometimes drugs like thiazides are associated with it. People with chronic renal disease can have reduced excretion, okay? Not as gout, but because of the renal disease. And there's a sex-linked, in other words, it's only in males, problem, enzyme defect in which you have a complete HGPRT deficiency. Therefore, you can't create nucleotides. Therefore, you have theoretically a relative overproduction of the uric acid with increased urinary excretion, but it's still, like primary gout, overproduction is the problem, not the excretion. Here are some of the risk factors. You could say, if we don't have a very specific etiology, even though we knew about some of the enzyme and defect genetic problems, age is a big thing. Gout is not a disease of young people. Gout is primarily a lot more common in men than in women. Okay, you can have that HGPRT X-linked enzyme defect, but in general, in the most usual types of gout, it's a multifactorial or multigenic inheritance patterns in which, the closer you are to family members, the more like with gout, the more likely you are to have it, okay? Alcohol can trigger off an attack of acute gout. A lot of heavy alcohol drinking. Somebody comes in after a binge, they get acute gouty arthritis. Okay, obesity. Okay, sounds like we're talking about Americans here. Okay, certain drugs, thiazides at the top of the list is always suspected when somebody comes in with gout. Perhaps still one of the most popular antihypertensives. And people, I was unaware of this, but I read it, so it must be true, in a reputable book. Lead toxicity. People that have been a toxic reaction to lead will also have a more of a tendency to develop gout. Now, if that wasn't enough multi-factors that are risk factors for gout, I'm going to tell you the two biggest ones. And that's going to be pretty soon. But the features, the pathology itself, is a development of tophi, or what they call tophaceous arthritis, or tophi in the joints, and also these same crystals blocking and doing damage to the kidneys as well. Here is a big toe, the most common place for acute gout to flare up. And in it, you can see there's been these thickenings around the joint. If you do not fix this tissue in formalin, but in alcohol, you can preserve the crystal. And you can see here's a clump of crystal, a tophus. And what are these little cells that are reacting around it? Well, these are inflammatory cells. These are primarily lymphocytes and macrophages, even multinucleated macrophages, which makes this a foreign body giant cell reaction. Here's a tophus deposit also, probably somewhere in the big toe. And here's our tophi being deposited around the joint space itself, and even in the bone, eroding into the bone, okay? This is the classical acute gout presentation. Here we are looking closer at the cellular reaction. Here are some crystals. These bluer areas are cells around it. I'm going to zoom in a little bit more. And look, you have crystals here, and then you have all these cells, and some of them are multinucleated, like you see here, and here, and here, and here. So what kind of cells become multinucleated? Macrophages, don't they? So this is a foreign body granuloma. So tophi are nothing more than foreign body granulomas to monosodium urate crystals. Here's some actual stones from the bladder. Okay, if you remember, we said that calcium stones are the number one type of stone in the bladder. The so-called magnesium ammonium phosphate are number two, but these brownish tan stones are classical for uric acid. And look at microscopically, you could even see that some of these crystals are kind of filling up the tubules as well. So that's the basis of the gouty nephropathy. Okay, now here is the part that I goofed up a little bit, because I'm going to now tell you the two general, huge, whopping, overwhelming risk factors for gout, in case you forgot those other 7 ones. One of them is atherosclerosis, okay, universal, and the other is hypertension. So this gout person that comes in and you have some of these factors like obesity, maybe some drugs, something in the family, he's a male. Also remember, this is going to be the same kind of person that probably has atherosclerosis and hypertension, which just seems like it's about half of every American adult or older American adult. I'm going to show you one more slide and then we're going to take our break. And it's something that you could be fooled about because it's not gout. So therefore, it's called pseudo-gout. And whereas gout are monosodium urate crystals, pseudo-gout are calcium pyrophosphate crystals. That's the big difference. So why would you have buildup of calcium pyrophosphate crystals causing an inflammatory reaction in a joint rather than classical gout, which is a whole different chemical? Well, there's a disease called chondrocalcinosis, and as you might expect, it might be calcification within the cartilage of a joint. It's sometimes probably more politically correct to call it CPPD, calcium phosphate deposition disease. I probably like that term better because that's exactly what it is from a pathophysiologic point of view. But basically, it's calcium phosphate buildup. Why would you build up calcium pyrophosphate? Well, you could do it as a complete unknown, which most of them are. You could have have it in the family, hereditarily determined, genetically determined, or you could have it secondary to other diseases, which would be obvious, like hyperparathyroidism. Too much calcium. A lot of that goes into the joint cartilage. What about buildup of iron or hemochromatosis, usually as a genetic disease, or a disease called hypomagnesemia, hypothyroidism, problem with nails, and even something as common as diabetes? You can have buildup of calcium pyrophosphate in joint, and specifically in the cartilaginous component of the joint. So it's been very often, actually I would probably say more than 10 times, where a doctor, a surgeon, a radiologist sticks a needle into a joint space in somebody that has an arthritis, and he asks you to look at the crystals that might be there under a microscope. Now this is kind of interesting. When you look at the joint space of fluid that's taken out in which gout might be suspected, as well as other things, including infectious arthritis, if you see crystals and they're needle-shaped and they're blue when they're horizontal and they're yellow when they're vertical, then you have pseudo-gout. This is calcium pyrophosphate crystals, are needle-shaped crystals that are yellow when they're vertical and blue when they're horizontal. Now, can I tell you the strange thing? This could also be sodium urate crystals, monosodium urate, okay? But in monosodium urate, the crystals are blue when they're vertical and yellow when they're horizontal. So strictly on the basis of polarizing the joint fluid, you don't have to do any stains, you don't have to do any cultures, but just looking at the fluid that the doctor sucks out of the joint space, if they are blue when they're horizontal, that's pseudogout. If they are yellow when they're horizontal, that's gout. So isn't it interesting that both monosodium urate and pyrophosphate crystals are the same, but they polarize completely in opposite directions. And sometimes you may have to turn the polarizer lens on the microscope to verify it. Or the best thing is to have a control, obviously. So that's gout versus pseudogout, depending on whether these crystals are yellow or blue, vertical or horizontal. They're opposites. Okay, we're going to take our break now and then come back and talk a little bit about not only joint tumors, but also some of the common soft tissue diseases as well. And like I say, this is not, I promise you, I'm going to keep my promise, this will not be a long webinar today. So let's do 3 more songs. Maybe we could pop up the, not the ugly guy, but the cute little critters. And play some songs for you for about 10 minutes. Here we go. Aaron Neville and Linda Ronstadt at the last song. I'm not sure if I spelled his name right. But we also heard Braveheart from the movie The Amazing Grace from the movie Braveheart. And one of my favorite old-time guys, Manilow. If somebody says Barry Manilow is one of their favorite singers, they're probably a depressed yuppie. Now, I live in Zion, okay? And there's two McDonald's in Zion down the main road, which is called Sheridan Road. And Sheridan Road kind of parallels the lake, and there's a big park that goes all through Zion and the next town north, Winthrop Harbor, all the way into Wisconsin, and the next town south, which is Beach Park, and all the way to Waukegan. It's like about 8 or 9 miles long, and it probably has like about 50 miles of incredible trails, and that's why I moved here, because I'm a big trail nut. But why am I saying this? I go to the McDonald's that's 1 mile north of me rather than the one that's 1 mile south of me, because they play all of these really old oldies. Like Barry Manilow is pretty old, I guess. Aaron Neville, Linda Ronstadt, not too old. And that's what I do to make myself in a good mood so I could give a good webinar. Okay, so let's get back to the relatively small amount of material that we're going to be talking about now. And that's, now that we finished joint, we're going to go to soft tissues. Okay, we're going to go to joint tumors, which is just a little bit on that, and then talk about soft tissues, maybe for 15 or 20 minutes. So here we go. We're back up to the PowerPoints. And I guess you could say, like all the tumors we talked about, we always start out with the benign. In fact, the ones that are not really true neoplasms, but bumps, like cysts or polyps or something like that. And then we'll talk into the primary, perhaps the only real significant malignant primary tumor of joints, called a synovial sarcoma. Wouldn't that make sense? The synovia have cells which multiply, and if they multiply in a uncontrolled, invasive, malignant, metastatic fashion, the good name would be a synovial sarcoma, because that is the part of the joint that has the viable cells that turn over. Without a doubt, one of the most common things, or bumps, I guess you'd call it a tumor, but it's really a cyst of the joint, is something called a ganglion. Okay? Now, not only does synovium line the joint space, but it also lines the tendons that may ultimately connect to those joints. So many of the tendons, you have a wealth of tendons in your wrists, both anteriorly and posteriorly, the flexor and extensor tendons. All those guys are surrounded by a little sheath of synovium. And you could have a buildup of fluid, particularly a mucoid type of, mucopolysaccharide type of fluid that makes it a cyst, and that's called a synovial cyst. But commonly they're called ganglions. You can also have what is called a benign tumor, because it's a proliferation of fibrous tissue and pigmented cells. So it's often called villonodular synovitis, or pigmented villonodular synovitis. And even though it's an inflammation, it's still regarded, it could be called a tumor because it's a proliferation of fibrous tissue. So I guess you could say it's both an arthritis and a tumor at the same time. And then, of course, you have your malignant variety here. So this one is not really a tumor. This one is not really a true neoplasm, but it's a proliferation of solid tumor. And this one's not only a real tumor, a real neoplasm, a real clonal expression of malignant cells, but it's malignant as well. Here's a ganglion. I used to work in the post office when I was in medical school, the main Chicago post office health section. And a lot of people came in with these little cysts on their wrists, either on the flexor or extensor side, dorsal or ventral, and almost certainly the diagnosis was ganglion, okay? Because the sheath that surrounded, in this case, the extensor tendons, became weakened and filled with this mucus type of fluid. Sometimes it's even more liquid than that. Sometimes these were actually sucked out with a needle. Sometimes surgery is done. And I think even in the old days, and I hope not too much now, one of the common treatments was to just hit it with a big, thick book and pop that cyst. And of course, it would go away, but it would release all the mucin into the, or mucopolysaccharide into the surrounding material. They're very common in people that use their wrists a lot, like mail sorters, for example. And that's why we saw a lot of this at the world's, at that time, the world's largest single post office in Chicago. Okay, here is the other type of tissue proliferation, but it's not a cyst. It is a true expansion of fibrous tissue. And if you look at this picture here, maybe I could zip it up a little bit. Whoa, I shouldn't have done that. But you could see that these little villi look like they're a little pigmented as well. Well, they're villi because they're expansions of fibrous tissue, and they're pigmented because one of the things that's in that is hemosiderin. Okay, it's an intrinsic pigment. And what do you have here also? Giant cells, multinucleated cells. Well, remember I told you that the synovium also has macrophages? And macrophages, when there's an inflammatory reaction, can coalesce their nuclei into one big cytoplasmic mass, like we saw with the gout as well, the foreign body reaction to the gout crystals. And that's basically pigmented villonodular synovitis, the S synovitis implying it's inflammatory, but they're also called GCTs, giant cell tumors. And of course, they're benign, okay? Now, could you have a malignant giant cell tumor? Yeah, in certain cases you have. You could probably Google some, but the name GCT is now practically synonymous with PVNS in the joint area and regarded as benign. And there are some little macrophages in there making those cells look a little more dark and pigmented. Here, let me see if I could find some hemosiderin in these macrophages. No, all I could say from this view is that these cells are a little darker than this. They probably have more hemosiderin. Not surprising, because that's just chronic blood pigment. What about so-called soft tissue tumors now? And I'll be talking primarily about soft tissue tumors, not necessarily soft tissue inflammations or soft tissue degenerations. If you think of what comprises the tissues in your body that are called soft, well, fat would be one of them, wouldn't it? Fibrous tissue, fibrous connective tissue, even if it's dense or loose, it's still considered soft tissue relative to bone, right? We had conditions there in bones and in dermis where we called certain tumors or proliferations fibrohistiocytic, simply because they look spindly like fibroblasts, but they also had some characteristics that they may have been histiocytes or macrophage, certain markers, for example. Well, skeletal muscle can be considered soft, couldn't it? It's certainly softer than the bones around it. Smooth muscle is soft. It may be rubbery like a Super Bowl, but it's still soft. It's not bone. Vascular tissue, vascular tumors, they may be very soft if they're filled with blood, or if there's not much blood, they may be a little bit firmer, like smooth muscle. Peripheral nerve can have tumors. Now, I know what you're thinking, well, wait a minute, if a peripheral nerve is nothing more than axons surrounded by Schwann cells, perhaps most or all of the so-called peripheral nerve tumors should be called schwannomas. And basically they are, okay? Even though there's a neurofibroma, which has more fibrous tissue. And then we're going to have some soft tissue proliferations, all of which are malignant. Remember, soft tissue is connective tissue. It's mesodermally derived tissue. So a malignancy of it would have to be a sarcoma and behave like a sarcoma. And these are all relatively rare. We said one of them was of the synovium itself. One of them were from cells that are still kind of mysterious, I believe, although I haven't attended any conferences on it lately. And one of them is a sarcoma of the soft tissues, but the cells themselves don't look spindly. They might look more epithelial, so you could mistake it for a carcinoma, but it's really an epithelioid sarcoma. What are some of the general factors, risk factors that cause these tumors of soft tissues? Well, for the most part, they're unknown, okay? We do know that radiation is something that can cause mutations in the growth control mechanisms of soft tissues. We do know sometimes they are associated with chemical burns, okay? That could also be causing initiator type carcinogen effect. Even thermal burns have been associated statistically more with soft tissue tumors. And also remember that soft tissue is fibrous tissue. So if you have a reaction to something by virtue of a fibrous reaction, that results in the cells in the fibrous tissue having a higher turnover rate, and that itself is a statistical association. Well, that might explain why sometimes trauma is regarded as a statistical association. Some of the soft tissue tumors, particularly a vascular tumor seen in immunocompromised patients, most commonly in AIDS patients, is a virus in the human herpes virus number 8 classification, causing Kaposi's sarcoma. And even though it's a sarcoma, it generally is regarded as a low-grade sarcoma. So if you've seen AIDS patients and they had red blotches and those were called sarcomas, most likely they were not going to die from the metastasis of the sarcoma. Sometimes you could rarely see them metastasize to lymph nodes, but they don't behave like real sarcomas going to lungs early. The genetics are very important. There's genes that have been indicted, and particularly chromosomes. I'm going to show you a big laundry list of many classical translocations of chromosomes, and when one chromosome translocates with another one, that might create a new gene, okay, called a tumor gene, okay? And I think I have the list right here. Yeah, so not only do you have a fusion gene, I called it a tumor gene, but they're called fusion genes, wherever you have one chromosome, usually translocating with another in the area of the translocation on the basis of the two genes now behave as a third type of separate gene called the fusion genes. And these are the particular genes that are associated with these types of soft tissue malignant proliferations in general called sarcomas. Okay, so you can have we talked about the Ewing sarcoma in kids, but you can also have in the bone, but you can also have an extraosseous Ewing sarcoma. And these are neuroendocrine cells. Malignant tumors of fat have been associated with translocations and fusion genes. Synovial sarcomas, rhabdomyosarcomas, not tumors of mature skeletal muscle, but skeletal muscle precursors. Okay, chondrosarcomas, extraskeletal. These are things you haven't heard of, are they? We can talk about clear cell sarcomas, a type of proliferation that's at least borderline called it's in the fibrous histiocytoma family. It's then called dermatofibrosarcoma protuberans. They're not totally benign. They're not totally malignant. There's what you call worrisome or borderline. A rare thing often seen in younger women called an alveolar soft part sarcoma, and kids that are born with congenital fibrosarcomas. These are all cytogenetic translocations primarily resulting in the creation of a fusion gene. Here's the definition, okay? There's a lot of controversy about what a fusion gene is, but basically it's a hybrid gene formed by two previously independent genes. One from one chromosome, the other from another chromosome, because in a translocation you have a crossing over. It can result because of an interstitial deletion, an fusion, translocation, and it's present in many, many types of these soft tissue tumors. I don't expect you to memorize them. I could never, I don't think anybody's capable of it, but you should know in these soft tissue tumors, particularly malignant ones, you can have these translocations between different parts of chromosomes resulting in a fusion gene. If you're looking at a soft tissue tumor through a regular microscope, most of the cells in general, benign and malignant, the cells look kind of spindly. Why? Because that's what connective tissue cells look like, fibroblasts. If the tumor is deep within the body, that's often called a desmoid. If it's superficial near the skin, it might be called a dermal tumor, which we talked about before. One of the most important things, not just in smooth muscle, but many or most of the soft tissue tumors, is to look at the mitotic rate. The more mitoses, the quicker it's growing, the more likely it is to be malignant. Okay, and remember, when these do become malignant, if it's they could very easily spread to the lung quickly, because sarcomas go quickly, generally speaking, through blood vessels, not lymphatics. If you wanted to know the origin of the cells, immunoperoxidase markers would help you a lot. You can always do these genetic studies to find out if these fusion genes are present. However, the most important thing is a consultation, okay? I don't think there's any pathologist I know that's alive that would ever sign out or diagnose any of these cases without showing it to other people. And throughout the years, even in my old days, but even now, there are certain people that are regarded as soft tissue tumor pathologists, and it's a very, very, very difficult job because you're dealing with sarcomas, which are serious, and even though there's a whole wide variety of them, like you see here, they basically may look very, very similar to each other. So let's go through the common components of soft tissues. How about if we start with fat? A true lipoma microscopically looks absolutely the same as normal fat. If I showed this picture, whether it was a normal fat or a lipoma, which may have a little fibrous capsule around it, to a pathologist and I told them it was normal fat, they'd believe me. If I told them it was a lipoma, they'd believe me. They're just fat cells. Most of the spaces are fat. You can see the little peripheral nuclei. However, the malignant counterpart of a fatty tumor, a liposarcoma, does not look like normal fat. It looks like the cells, the nuclei, are bigger, plumper, darker, pleomorphic, hyperchromasia. You already know all the adjectives by now. But they have a certain type of cell which are big and dark and plump, and they might call those a lipoblast. There's fat still in association with this tumor and the cells. So that might be one of the features, okay? What about regular old fibrous tissue, which is primarily fibroblasts, making collagen? Well, you could have a proliferation of that tissue in a nodular fashion, and that might be called nodular fasciitis. If the arrangement of the cells is worrisome in terms of dark, ugly cells, perhaps increased mitotic activity, you might put in the word pseudosarcomatous, which means it's probably not a sarcoma, but it looks like it. And these are the things that really scare most pathologists, including me. There are certain conditions in the body, like in the plantar area of your foot or the palmar area of your hand, or in the penis, which are called fibromatoses, resulting in the tissues being contracted because of the production of collagen, making it look like a scar. Okay, I don't think you would call that a neoplasm, but you call it a benign proliferation of fibroblasts. On the other hand, there is such a thing as a true fibrosarcoma, okay? And very often the word herringbone is used, like you see here, to describe a fibrosarcoma, because it looks like fibers are going one way and then fibers are going the other way, and then fibers are crisscrossing again. Very much like you would see in a herringbone pattern. Now, if you ever cut the bone of a herring, you might see something like this. On the other hand, I've noticed that a lot of the home decorations are often talked about as having sort of a herringbone pattern. So it wouldn't take much of an imagination to see that this crisscrossing in a regular way could very easily represent the poles of the fibrosarcoma. Malignant tumors that may look like this, which think are fibroblasts, are often, however, in the fibrohistiocytic family, which we saw in the skin, which we saw in the bone. Another type of proliferation, perhaps not a true neoplasm, is something called myositis ossificans. Well, the myositis may be a little misleading because it's not in necessarily muscle tissue. It's usually in soft tissues, okay? And the ossificans period or term is probably more correct because it means not just calcification in soft tissues, which is very, very, very common following chronic inflammation and fibrosis, but actually ossification, okay? So here you have a leg, here you have perhaps a muscle or soft tissue surrounding it, and then you can see within this soft tissue, something that doesn't just look like calcium, but if you examine it microscopically, it has many of the features of bone. It has true osteoblasts. So why does this happen? It happens because somehow, usually following injury or as a reparative process, not only is there fibrosis and calcification within the soft tissue, but there's some mysterious problem in which it produces bone. It's not malignant bone. It's not probably what you would call a neoplastic process, but myositis ossificans is what we call a metaplastic process. Remember, in metaplasia, you have one normal type of tissue, like bone, replacing another type of tissue, which is fibrous tissue. So myositis ossificans, it's not a true neoplasm, it's not a malignancy, it's not a true tumor, but it's a metaplastic process, usually following injury where bone replaces fibrous tissue. Now here's the so-called fibrohistiocytic tumors. Most of the things that we called dermatofibromas in the skin are probably better termed fibrous histiocytomas. They're not just fibroblasts. They have markers which make them think that they might be related to macrophages or histiocytes. Okay, you could have a bigger proliferation of that same type of tissue and be a little bit atypical and big, and it protrudes, okay, way above the skin. And that's how it got the name dermatofibrosarcoma protuberans. And technically, these are benign, but they can look a little worrisome, okay? On the other hand, they can look downright malignant, like you see here. Big, dark, ugly, haphazard, spindly cells. This one would be easy to diagnose even for me. This one, I think nobody would ever diagnose without getting a consultation to make sure it wasn't really a sarcoma, because even though it has the word sarcoma in it, it's not a malignant connective tissue expansion. Here's skeletal muscle, and here's something called a rhabdomyoma. So you would think, well, this is going to look a lot like skeletal muscle, and this might resemble skeletal muscle at first glance. There's no striations, but you can see the nuclei are at the periphery, and this would be a rare tumor called a rhabdomyoma, seen technically wherever you have skeletal muscle, including the heart, by the way, or striated muscle. Here is a rhabdomyosarcoma. These malignant, obviously dark, ugly, pleomorphic, hyperchromatic cells are not derived from these cells, but they're derived from the cells that give rise to these cells. And we find an example of that in the female genital tract in young children, young girls with a rhabdomyosarcoma, also called a sarcoma botryoides, okay? Smooth muscle. Where would you get a smooth muscle tumor? Well, it's wherever you have a smooth muscle. In a woman, the greatest amount of smooth muscles in the uterus, so that's where most of the leiomyomas are, but they could be smooth muscle of blood vessels, smooth muscle of the stomachs, anywhere where there's smooth muscle. And of course, if they involve the endometrium very much, that could interfere with implantation and so forth. But even though they are well defined and they look rubbery, they're not perhaps exactly the same color as the normal muscle. Microscopically, if I showed the world's last 10 pathologist Nobel Prize winners this picture, and I said, this is normal smooth muscle, they'd have to agree with me. But on the other hand, this is actually smooth muscle from a leiomyoma, or benign smooth muscle tumor. You can't tell the difference between normal smooth muscle and a benign, if you don't mind the redundancy, leiomyoma. On the other hand, you can have a smooth muscle tumor that is very ugly looking. You could have dark, irregular, big and small cells. So you might be tempted to call it a leiomyosarcoma, and it could be. However, the thing I want you to remember forever is that the difference between a benign smooth muscle tumor and a malignant smooth muscle tumor is not necessarily how dark and ugly and big the cells are. It's the number of mitotic figures that you can count. So even though there may be a lot of dark ugly cells here, if there aren't many mitoses, it's more likely to be benign. So mitotic count, before you do, a lot of special studies, is the most important way to differentiate benign from malignant smooth muscle tumors, not pleomorphism. Vascular tumors. Well, we talked about them already because we talked about vascular diseases. We said benign hemangiomas, by definition and behavior, are benign. Same thing technically with tumors of lymphatic vessels, okay? There's a couple of tumors which are at least borderline or perhaps regarded as low-grade malignancy. One of them, even though it doesn't have a malignant sounding name, a hemangioendothelioma or a hemangiopericytoma could invade or behave in a malignant fashion. And of course, the blood vessel tumors that are obviously, unquestionably, undeniably malignant and behave like any sarcoma would behave, perhaps early vascular metastases. Those can just be called angiosarcomas. I think I have one more slide, maybe, or two. I don't know. Oh, well, we're going to be talking about peripheral nerve and muscle diseases in the next webinar, but you can technically have tumors of a peripheral nerve because peripheral nerves have cells. Now, the axons themselves don't become tumorous, but the cells that surround them, the fibroblasts, and particularly the Schwann cells, the Schwann cell is a cell that basically insulates the axon with a fatty coat, okay, myelin. Those cells can become proliferating, usually benign. But I bet you right now, if you Googled malignant schwannoma, you'll probably find some cases. There are granular cell tumors, okay, which are basically tumors ultimately from cells giving rise to peripheral nerves. And of course, you can have a malignant schwannoma. I don't think I've ever seen one, and probably if you see 10 schwannomas, you might see maybe one malignant schwannoma. But basically, those are the only nucleated cells, the primary nucleated cells that surrounds a peripheral nerve. And finally, I'm going to throw at you as our last thing, uncertain, even after all these years, even when I was a resident, we never really understood what was the origin of a synovial sarcoma. But synovium, if you remember, it has fibrous tissue. It has fibroblastic-like cells. It has macrophage-like cells. But basically, they can become malignant. Another tumor called soft part, I believe, is still mysterious in terms of the origin. Often seen in younger women, but that's a soft tissue malignant tumor of still kind of mysterious and very rare. And finally, technically any sarcoma, if you remember, sarcomas would have to have spindly cells because they're connective tissue cells. However, they can often look epithelial or carcinomatous. So an epithelioid sarcoma might be called a carcinoma just on the appearance of the cells. But then if you did certain cell markers, you would see that these cells have the antigenic markers of connective tissue rather than epithelium. So we're done with our webinar for today, and it's only a little bit more than an hour and a half. I didn't break my promise to you. In the fourth discussion on SMS, skin musculoskeletal, we'll be talking about myopathies, disorders of muscles, primarily skeletal muscle, and also neuropathies or disorders of peripheral nerves. We've already talked about tumors a little bit, but we'll talk about them more, and we'll talk about other diseases of striated muscle and nerve. So we could go home now. Whoops, you already are home. So am I. But how about if we play our final song? And it's also going to be not only one of my favorite songs of all time, but it's also one of my wife's favorite songs. It's by a group that is reminiscent and the most famous group that ever came from my city, Chicago. And it's called You're the Inspiration.
Our love was meant to be kind of love to last forever, and I want you here with me from
Rock on, buzzards. And if I were you, I'd also take the advice of the rock group Chicago. By the way, my wife knew one of the guys in the rock group Chicago because we're both from Chicago. But if I were you, I would take their advice and be somebody's inspiration. Rock on, buzzards.